Well, the short answer is that using logistic regression, there was no difference in overall complications, in major complications, or infection between the two groups, which was very good because our initial hypothesis was placing the implant in front of the muscle rather than in the subpectoral position could have some complications. And what was also interesting is using patient-reported outcomes using the breast Q. There were similar results between the two. And interestingly, prepectoral reconstruction had a 33% lower number of office visits to take care of the expansion. And the time between the placement of the tissue expander and the exchange to the implant was 33% faster. And when we looked at overall all of the patients, including both groups, as one would expect with most plastic surgery operations, obesity was horrible. And in fact, it was an independent predictor for just about everything bad in terms of complications, including infection and explantation. And I could say from a personal point of view, when prepectoral reconstruction started, I knew a number of the pioneers and early adopters of the technique, and that really didn't think that that was a great idea. I never thought that it would be a good idea to go back into the 1970s where we placed the the implant subcutaneously as opposed to behind the muscle, with the muscle protecting the implant and covering it for an aesthetic purpose. But one of my faculty members sort of had me do a prepectoral reconstruction. I finally agreed to it. And I'll tell you, I walked out of the operating room that day and I said to myself, I will never raise another pectoralis muscle for breast reconstruction if I can help it. It was a fantastic experience. And I can tell you the advantages from this study and from others of prepectoral reconstruction is the surgery is much faster. I can generally finish a prepectoral reconstruction skin to skin within 20 or 30 minutes if everything is prepared correctly. There is considerably less pain in patients who have this. The muscles are not cut, they're not pulling on the muscle. This translates into less opioids, and most patients are able to go home on Tylenol and Motrin. The faster recovery is obvious. The expansion is faster and less painful. And there's, most importantly, this is really where the concept of prepectoral reconstruction came in, is to avoid the animation deformity associated with the pectoralis muscle. And in fact, I've had patients come in who have had a subpectoral reconstruction and asked to have what I call a lane change, which basically means we take the pectoralis muscle, dissect it off the skin flap, and secure it back to the chest wall and place implants in front of the muscle to eliminate the deformity. And I think the other issues regarding the pectoralis muscle, while it has some benefits, there are some shortcomings as it relates to window shading. That is when the pectoralis muscle is still functionalized and still contracts and lifts up towards the clavicle and can be concerning and have an aesthetic issue as well. And there tends to be a flattening of the cleavage area with the muscle not expanding as well as the rest of the breast. So these are areas that are much improved with prepectoral reconstruction. And there are some disadvantages. I think one of the theoretic disadvantages that was one of my initial concerns is in the event of wound dehiscence. I would much rather be seeing at the base of the wound a pectoralis muscle rather than the implant itself. But that has not turned into a real issue in our practice. And the other issue is with the radiation oncologists. One of the issues with prepectoral reconstruction, different than subpectoral reconstruction, when you have a subpectoral reconstruction, the anterior and posterior margins of the mastectomy specimen are applied directly to each other and are above and in front of the implant. So the radiation oncologists need to target that area above and in front of the implant, whereas in prepectoral reconstruction, the posterior margin of the mastectomy specimen is on the chest wall because the pectoralis muscle is still on the chest wall. So all of that area needs to be addressed and targeted, which can lead to dose inhomogeneity as well as some issues related to the mammary node chain. So it's just a larger target. But overall, prepectoral reconstruction is here to stay. And I can't tell you how much I enjoy doing it as compared to postpectoral reconstruction. I can tell you that historically, the concept of performing an implant-based reconstruction after a failed implant-based reconstruction due to infection has been thought of as a disaster, largely due to the concept if plan A fails, don't make plan B the same as plan A. But in my experience, I was not seeing that. There's a number of patients that are adamant about having implant-based reconstruction and not having autologous reconstruction, something that we do all the time and we enjoy doing. Or patients are not a candidate or a good candidate for autologous reconstruction, and they are adamant about having implant-based reconstruction. And of course, after a failed reconstruction, autologous reconstruction is always a great option. It has almost a 0% infection rate, and there's no device, there's no foreign body. So that is a great option. But again, you're looking at a patient population who, through shared decision making, has decided with their surgeon to go with an implant-based reconstruction for whatever reason. Their own choice. They're not a candidate for others. They don't want to go through a larger operation. So these patients have committed to implant-based reconstruction, and oftentimes they want to continue with this. And that's really the focus of this study, is to look at is that reconstruction a second time going to be a failure, or how successful can it be? And we were fortunate enough in this situation to have over 6,000 patients to be able to study. And we looked through those patients and we identified patients who had failure due to infection with explantation. And not all of those went on to implant-based reconstruction. Obviously, there were patients who had autologous, there are patients who had nothing done at all, patients had latissimus flaps. But we studied the patients who had a second implant-based reconstruction with a device. And when I say device, I mean an expander or a permanent implant. And what we found in that group, after a second implant-based reconstruction, there was indeed a higher infection rate and a higher explantation rate. In fact, 21% versus 9 and 5% respectively. But when you look at it, if the explantation rate in that patient population was 21%, that correlates to a 79% success rate. And actually, that's pretty good compared to what many surgeons would consider a real disaster in performing a second implant-based reconstruction. And if you exclude patients with radiation, that success rate goes up to 88%. That actually is good. 8 out of 10 patients will have a functionally successful implant-based reconstruction. Of course, that doesn't include aesthetics, but functionally, that's a very good result. And when you look at timing of a secondary reconstruction, that actually makes a big difference. There are basically two ways to perform a secondary reconstruction. One of which, and I don't advocate this, is when you go down to the operating room for an explantation, you remove the implant, you irrigate the pocket, do a capsulectomy, whatever you do to the pocket, and then you place a brand new implant expander into that pocket right away at the same operation. I don't advocate that, but a number of surgeons have done that. The second way, which I advocate all the time, is to do a delayed reconstruction. That is to say, close the pocket over drains, let that heal, come back at a second setting, and place the device at a time. And it makes a big difference. In fact, it also makes a big difference at how far you delay that. So patients who are reconstructed in a delayed fashion before 6 weeks do much better, lower complication rates, lower explantation rates than those after 6 months. Now, of course, there's some bias to that because I think that patients and surgeons who have had a severe infection, something that you really can't capture in patient records, they are very reluctant to go back in early on and experience the same emotional and physical trauma of having that severe infection. So that's probably some bias to that. But I think if you can perform these procedures, if you exclude radiation, if you perform the delayed reconstruction within 6 weeks, and you don't do it immediately at the time of explantation, the success rate is far above 90%. So that's over 9 out of 10 patients who are able to get a successful implant-based reconstruction. And this is something that is absolutely game-changing in terms of what many surgeons have thought in the past, that a second reconstruction is a disaster. And in fact, we studied patients who had a second reconstruction that failed and subsequently underwent a third implant-based reconstruction, which would have really, in essence, many surgeons would have thought that was crazy. But in reality, obviously, these are highly selected patients. There were very few patients. I think there were 9 or 10 patients in the study. But after the patient selection, there was a 78% success. So that is actually pretty good. I think the moral of the story is if patients have an implant-based reconstruction and they're not a candidate or they don't want to undergo an autologous reconstruction after failure, implant-based reconstruction is an option and has actually very good results. Mastectomy skin flap necrosis is unfortunately one of those problems that plastic surgeons have to deal with that we were not the cause of. And it can be very emotionally concerning and physically an issue for the patient. And we have to look at mastectomy skin flap necrosis. And as we know, after a mastectomy, the blood supply to the mastectomy skin flap is simply from the periphery of the breast skin, because during the mastectomy, the perforators that go through the breast are transected. So the blood supply to the mastectomy skin is best at the periphery and potentially least where the nipple was that correlates to where the incision is. So if there is ischemia in the central area of the breast, it's generally like a burn. It's not just completely alive and then completely dead. There is a zone like a burn. There's a place that is going to be completely not alive. There's a transition zone that is struggling with ischemia. And then there's a zone where the skin is completely perfectly well vascularized. And the way we assess this is with quality, quantity, and over time. So with the quality, we look at, and we've studied this and we've published on this, is we look at full thickness versus partial thickness. And then we look at the quality, the quantity, which is the surface area of the area of necrosis, and how long along postoperatively. And what we see is early on, within the first week, usually you can't tell oftentimes what's going to be full thickness, what's going to be partial thickness. Maybe there won't be any full thickness necrosis at all. So as time goes on, there's a demarcation of the full thickness necrosis. And that zone of transition becomes much thinner, which is a good thing when you excise it, because you don't want to be excising in a zone that is partially well vascularized, because that has to heal to the other side. So what we typically do is we watch these patients frequently in the office, and if it's all partial thickness, then we're done. Basically, that patient heals with very little or no scarring in the area. But if there is a demarcation of full thickness necrosis, What we want to do is we want to excise that and reclose that. Now, to do that, most of the time, if you're excising a percentage of the mastectomy skin surface area, then you need to deflate the expander to be able to do that, just to be able to get that closed. And of course, we go in and do this. We do this under local in the office. And we, of course, send that off to pathology. We use a no-touch technique. We take cultures, we irrigate out, and we're very meticulous about our technique. And that works out very, very well. Now, the rub on this is if the device that was placed at the time of surgery was direct to implant rather than an expander, that implant is fully expanded. You can't deflate that. And by excising any significant amount of the surface area of the breast, oftentimes that skin can't be closed or it's closed under too much tension. And under those circumstances, we need to go back to the operating room and excise the skin. Generally, we'll remove the permanent implant, place a partially deflated or completely deflated tissue expander, and close the skin and convert that to a two-stage reconstruction. So in essence, it's a balance between demarcation and wound separation and infection. Because as you know, the dead tissue at the incision level, dead tissue does not heal to dead tissue, and dead tissue can cause an infection. And over time, the dead tissue that is connected to the opposite side of the wound is really connected primarily by a mechanical action from the sutures that were placed. So there can be sort of small little microscopic holes in that incision or a full-size wound dehiscence, allowing bacteria to get in and contaminate the space within the mastectomy skin envelope and potentially develop an infection that could be problematic. So those are the sort of ways we do that. There's a lot more details to this and a lot more finesse, I would say. But in general, this is a highly effective strategy. What we say is when we think it's going to work, it almost always works without having an infection and explantation. And when we think it's 50-50, it almost always works. So it is a very effective way to manage mastectomy skin flap necrosis. Oncoplastic reconstruction is something that plastic surgeons have really pioneered, and I think it's one of the most innovative techniques that plastic surgeons have done and has led to the greatest improvement in outcomes for patients who have undergone partial mastectomy. I remember training in Boston in the 90s in general surgery. And when we would do a partial mastectomy, we wouldn't even think about doing anything else. We would just leave it. It would cause a seroma. There would be a contour deformity and a divot in that area. And we just sort of, the patient managed it. But now we have other techniques. And when I think of oncoplastic reconstruction, there's really two types. One is local tissue rearrangement, and the other one is performing a mastopexy or a reduction type procedure to disguise the defect, the contour deformity. And the local tissue rearrangement really is just moving tissue around where that excision was performed and not doing anything else to the remainder of the breast and not doing anything to the opposite side. Whereas a mastectomy or a reduction type pattern oncoplastic reconstruction is exactly that. You're basically doing a mastopexy or a reduction of some sort. And in doing so, you're using that tissue to replace the defect and disguise it so it is not as easily visible. And when making a decision to perform a mastectomy or a partial mastectomy, or if you're going to do oncoplastic reconstruction and a partial mastectomy defect, whether you're going to do local tissue reconstruction or a mastopexy type oncoplastic procedure, there are a number of considerations. And one of the most important things is the size of the tumor compared to the size of the breast, because you can imagine if you have a very large tumor and a very small breast, that's not going to work out very well. And aesthetically, no matter which procedure you perform, that generally is not going to have a good aesthetic result. The other consideration is the location of the defect, both around the clock, around the periphery, as well as the distance from the center of the breast or from the nipple. So in the areas in the superior pole and superior medial pole, on the clock, basically, these are the most cosmetically sensitive areas in a bra, in a bathing suit, even in a gown or in clothing. That area is either visible by looking at the skin or through the clothes under the skin to be able to see a contour deformity. So those are the most sensitive areas and are a major challenge, particularly because of the teardrop shape of the breast, whereas the upper pole has much thinner tissue and there's not as much tissue to use to sort of replace the defect. And again, the proximity to the nipple is simply because the breast in the center and the lower part of the breast is much thicker. There's more tissue to disguise it. The other issue is where the nipple is placed. So if the nipple is in, a perfect position or maybe even a little bit higher, that makes a mastopexy or reduction type procedure, particularly if it's a small breast, not a good option or maybe not an option at all. So the pros of local tissue reconstruction, and again, it's a very limited scope of being able to help that contour deformity because you don't have much tissue to work with in that local area most of the time. It is less invasive. It doesn't take very much time to do that. You're only operating on one breast. It's all through that incision. But again, the downside is you have a limited ability to take care of that contour deformity. And using a mastopexy oncoplastic reconstruction, there is excellent tissue redistribution. Most of the time, particularly if the defect is in the lower pole, you can't even tell that there was a defect at all. And surprisingly, one of the major benefits of this procedure, particularly when we do both sides, we do a symmetry procedure, is that the patient receives a mastopexy or reduction, and many times the patient had been thinking about getting one of those procedures all along, and now that procedure is combined with an oncologic procedure. In fact, patients sometimes they come back to the office, and I'll ask them, isn't it great to have your cancer removed and on your way to recovering? And they say, well, cancer, yeah, that's great, but I got a mastopexy or I have a breast reduction that I've been wanting for years, and now I'm very, very happy. So that's another benefit. And the downside is that most of the time we'll do both breasts. So we're operating on a non-cancerous breast. That sometimes is an issue for some patients. You can delay that side if need be, or if it's a small reduction, maybe you won't have to do anything to that side for symmetry. And again, not a good option for patients with small breasts, nipples that are in the right position. And again, it's more invasive surgery. You're doing a more extensive surgery on one side, potentially on both sides, which increases the wound healing complications and everything that's associated with that, including operative time and recovery. So oncoplastic reconstruction is perhaps one of my favorite operations to do because the learning curve is not very steep, but it extends very long. I learn something new from every single case that I do in oncoplastic reconstruction. And to me, it still fascinates me to this day. Let me clarify the study design. In both groups, there was primary fascial reconstruction. In other words, the fascia was closed and there was a mesh used. The difference was in the component separation group, there was an additional procedure performing anterior component separation. So the only difference between the two from a procedural point of view is component separation was used. And the short answer is component separation reduces hernia recurrence significantly. In this particular study, the component separation group had a 5.3% recurrence, and in the primary fascial closure group, it was 10.8. So roughly half of the hernia recurrence rates by using component separation. And the important aspect of essentially all abdominal wall reconstruction studies is the length of follow-up. We all know if you follow patients who had abdominal wall reconstruction, hernia reconstruction, over 1 year, 5 year, 10 year, you'll see that at short follow-up period of time, the hernia recurrence rate will be very low. But over time, the hernia recurrence rates increase significantly. So we generally consider 2 years as sort of an adequate follow-up time, 5 years as standard, but most studies do not make it to 5 years. It's hard to get a 5-year study. This particular study was 2.6 years mean follow-up. So that's a pretty good follow-up for this type of procedure, this type of population to study. And what we found using multivariable logistic regression is that component separation in itself, controlling for all other factors that we studied, was a protective factor, independently protective against hernia recurrence. And the odds ratio for that particular regression model was 0.1, which confers to a 10-fold reduction in the risk of hernia recurrence just by performing component separation. And when we modeled for surgical site occurrence, component separation was not predictive for that. And one of the reasons why that's important is you're adding a procedure. You're adding a procedure that adds subcutaneous dissection, additional operative time that could potentially result in increased surgical site occurrence. But using logistic regression, that was not a predictor. Now, there were some consequences. There was a higher rate of wound dehiscence, fat necrosis, and seroma in patients who received component separation, but that I think is a minor consequence. And looking back at this study, this was a very unique study. We looked at the effect of component separation in a lot of different publications, but this was focused specifically on component separation. And this study, we were just very lucky to have the patient distribution that we did. The odds were stacked against the component separation group from having a positive result. The hernia recurrence was much less despite all the odds. And one of the things you have to keep in mind is that in our practice, CT scans are used in almost all the patients to follow their oncologic results, and in some cases to evaluate whether or not there's a hernia if a hernia is suspected. So in this particular study, 89% of the patients had a postoperative CT scan. And one thing we know from our research is that by using CT scans, if there's a hernia, we are going to find it. In fact, we found when you suspect a hernia, imaging such as CT or MRI is 100% accurate in determining hernia, whereas a physical exam is roughly 50, 60, 70% accurate to do that. So using CT scan, it's going to confirm hernias in almost all the cases, if not all the cases. Now, this patient population that was in the component separation group had larger defects, wider defects, higher BMI, longer follow-up, we know is an issue, had a component separation procedure, which is added on, so that's additional surgery, and had twice as many paniculectomies than the primary fascial group. So all of these factors are factors that should increase the risk of hernia recurrence, whereas in our study, we had a reduction in hernia recurrence. So that was a really great study, because sometimes the distribution of patients is not favorable, where you say, oh, the result may not be related to component separation, could be something else, but everything was stacked against it. Despite that, there was no additional operative time. similar OR time. There was less blood loss, and the patients went home earlier, which is very surprising. I think the most important thing to take away from this study and emphasize how important and how beneficial component separation is that the indication we use for performing component separation is when the fascia cannot be closed without undue tension or can't be closed at all. And that's when we use component separation. And the patients where you can't get the fascia closed without undue tension, they're the patients that are the highest risk for any recurrence. So despite that, our component separation group was positive. So I can say in summary that component separation is a very valuable technique. And I would say learn it, master it, teach it, and use it. Thank you for this question. This is something near and dear to my heart. We've studied this in a number of different publications, and the simple answer is when you're using bridging. And let me explain for some people who don't understand exactly what bridging is when you cannot close the fascia completely, so coapt the two fascial edges together, there is mesh bridging between the two fascial edges. And we've over the years identified the fact that in our clinical practice, anecdotally, we were finding hernia recurrence rates were much higher in that group, so we decided to study it. And the bottom line is you should avoid bridging at all costs. And there are ways to do that. We heard about component separation. You can use preoperative Botox or neurotoxins or preoperative pneumoperitoneum to help be able to reduce bridging. And as we've studied this in a number of different studies, bridging increases hernia recurrence tremendously. In fact, using logistic regression, it is a predictive factor for hernia recurrence. And over a number of different publications, the odds ratio have varied from 2.5 to 9.5. So that's basically a 2.5 to 9.5 fold increase in risk for hernia recurrence. And for those reasons, we believe that if you can avoid bridging, that should be done. But that's not the whole story. By bridging these patients, it increases the complications overall by a factor of fourfold. And if patients are going to develop a hernia, the time to develop a recurrence is ninefold faster. So these are other consequences of bridging. So if at all possible, do not bridge your reconstructions. Reducing hernia recurrence, this is a very important aspect of abdominal wall reconstruction. We've been looking at this for decades. And there's one thing to take into consideration. There are what we call modifiable and non-modifiable factors. So for example, a patient who's coming in for any operation who's 73 years old and weighs 500 pounds. Well, you're not going to be able to change the fact that the patient's 73 years old preoperatively. But you may, if you have enough time, be able to change the patient's BMI by exercise, weight reduction, surgical weight reduction, Ozempic, or whatever it may be, to be able to improve the outcomes of all factors of the surgery. So that's one thing to keep in mind. Some factors you can change and something you can't. And one of the things we studied over a few years ago is surgeon experience. It's something we talk about, excuse me, all the time in our hernia conferences and hernia meetings is getting the first option done correctly. And choosing your surgeon is incredibly important. What we found when we studied surgeon experiences is highly experienced surgeons have a fourfold lower recurrence rate than surgeons with low experience. So it's really important if you have a hernia to choose your surgeon wisely. And one of the consequences, if there's a failure after your first hernia operation, the second, third, fourth hernia operation are very challenging. Many of the tools we have are bridges burnt, and the complication rate and the hernia recurrence rate are very disappointing in second and third operations. So get the first operation performed by the best surgeon possible. And you've heard about two other ways of reducing hernia recurrences. Don't bridge and use component separation. We've also identified in a number of different studies is that obesity is a predictor for hernia recurrence. So again, if you can have the patient lose weight, that improves hernia recurrence, as well as essentially almost all of the outcomes in plastic surgery reconstructions, as well as abdominal wall reconstructions in particular. And of course, just like any other procedure, you want to optimize the medical conditions. You want the patient to be in the best condition. So if the patient has diabetes, you're going to want to optimize their blood sugars, their hemoglobin A1C. They have cardiac disease like hypertension, you want their blood pressure under control. Pulmonary disease, you want their exercise tolerance as best as possible, and you want to optimize their nutrition and things along those means. So you want the patient in the best shape to get the best outcome. And the last thing that I'll sort of touch on, and this has not been studied and is a little softer, but postoperative activity restriction. We don't know exactly how important that is, but we generally have patients do not do exercise and certain activities for several weeks to months. And I would say that I would not want my patient leaving the hospital after an abdominal wall reconstruction and entering into a triathlon. And most patients don't want to anyway. So that's another important thing. So these are all mostly proven ways to reduce the risk of hernia recurrence. And I would say when tackling these complex procedures in many cases, utilize all that you possibly can, because getting a hernia recurrence is really a bigger challenge than meets the eye. And with the first hernia recurrence, the second operation, the risk of having a hernia recurrence is much higher, and it goes down with each subsequent operation. So those are the sort of ways to reduce hernia recurrence. I'll have a disclaimer first that when I sort of developed this concept a couple decades ago and started using it and popularizing it, there was not a whole lot of robotic surgery. And in today's world, minimally invasive surgery oftentimes is a knee-jerk response to this is done with a robot or with a laparoscope. And that's not the case. This is really open surgery, minimizing the amount of undermining and dissection that is being done. Of course, you can do it with a laparoscope. You can do it with a robot. It's done not that commonly, but that's certainly an option. And minimally invasive component separation is a concept of using subcutaneous tunnels to accomplish goals of anterior component separation, which is twofold. Number one is incising or releasing the external oblique aponeurosis and dissecting between the internal and external oblique aponeurosis to be able to medialize the rectus complex and to be able to get the fascia closed without as much tension. Now, to do that, the minimally invasive component separation starts with a subcutaneous tunnel, usually about 3 or 4 centimeters in width, over the anterior sheath of the rectus complex. Usually we perform this in the subcostal region, and that is dissected to the semilunar line and just beyond. And the area in which you would be incising the external oblique aponeurosis is identified, and that is incised vertically for about a centimeter. So basically what we're going to be doing is we're going to be doing component separation in reverse. First, we're going to be doing the dissection between the muscles, and secondly, we're going to be releasing the external oblique aponeurosis. And so to perform the dissection between the internal and external oblique, oftentimes what I'll do is use a blunt instrument. I use a sucker handle that is not on suction, obviously. I insert it into this defect in the external oblique fascia and slide it in, and with a sweeping motion, dissect the avascular plane between these two muscles. And that accounts for 80–90% of dissection. Some of it can be done at a later time point. So we've done the second part of the operation first. Now what we need to do is release the external oblique aponeurosis. And to do that, we make a vertical tunnel. So the area that we're going to be incising the external oblique aponeurosis, which is about a centimeter, centimeter and a half lateral to the semilunar line, we want some space above and below. We already have space below because we've dissected between the two muscles and the aponeurosis. So to get space above, we dissect over that area in the subcutaneous plane, usually with a long electric cautery. And to do this, we use that same blunt instrument. We push it up against the semilunar line, and the instrument usually is about a centimeter in width. So we use that as a palpable and a visual guide to dissect a 1 or 2 centimeter tunnel from the costal margin and above all the way down to the pubis. So we go inferiorly first, we dissect, and we use the visual aspect and the palpable aspect of that instrument to dissect over that area all the way down the pubis, all the way above the costal margin. So we have space above and below the area we're going to release. And then we actually, through the tunnel, we release the aponeurosis. We use scissors inferiorly, usually, and then superiorly we use scissors and electric cautery because the upper aponeurosis turns muscular as you go above the costal margin. And after this, we can do some additional dissection between the muscle with electric cautery. So we've performed the complete anterior component separation. And what we've done is essentially, we've done two things. We've spared the rectus abdominis perforators. That is blood supply to the central skin. And that skin needs to heal to the other side to be able to reduce the risk of wound healing complications and separation of the incision. So we've increased the vascularity of the overlying skin. And perhaps as importantly, is we have not undermined the subcutaneous tissue over the rectus complex in most of the areas. And that reduces the undermining and elevation of large skin flaps that can result in dead space, seroma formation, and infection. So those two goals are sort of the paramount aspects of minimally invasive component separation. I can tell you that it has been incredibly beneficial to do. The learning curve is fairly steep. I would recommend people who want to start doing this procedure look at the original article and descriptions and photographs, perhaps look at videos that are available in doing this to be able to get a better sense of exactly how to do this correctly and just start doing it. It has really made a huge impact on my practice and has improved outcomes in abdominal wall reconstruction. Well, I'll concentrate on the research process. I can say that research and scientific writing or manuscript preparation is not generally taught in a formal fashion in most centers. Some centers are better than others, but I think there's a lack of formal training in that area, and that's a consequence to plastic surgeons. The other issue is plastic surgeons uh, are not typically getting large federally funded grants. We get grants that are smaller, so funding this type of research can be an issue. I know that I've funded much of my research, both basic science research and clinical research, with either grants that I've received, endowment funds, or more recently, I was able to establish an endowed uh, clinical research fellowship that will live in forever, basically, um, that supplies funding for salary, travel, and some of the research costs. And that was, it's called the John Harper Endowed Research Fellowship. And that fortunately will live in perpetuity. But most places do not have that type of funding available. So funding can be an issue and can be a challenge. The other aspect is identifying a mentor. I can't stress the importance of having a good mentor. This will make or break your research success and your research career. And in looking at all the aspects of performing research, whether it's clinical research or it's basic science research, I personally think the most important thing is study design. Developing the appropriate study design, including methodology, control groups, statistical analysis, et cetera. It's the most important aspect. If you don't have a good study design, you're not going to have a good study. You're likely not going to have a good paper, and it's probably not going to get accepted into a reasonably good journal. Having a good study design from the beginning will set you on a path for success. And the way to sort of understand how to do that, as well as other aspects in research, is to review a lot of papers. So I review thousands of papers as an editor or as a reviewer for a number of journals. And by doing so, it's very valuable to have the experience to do that. So whenever you get a chance to review papers, that's something that you should take upon yourself, particularly those journals that allow you to see the comments from more senior reviewers, and you read through those comments and you say, "Oh wow, boy, I missed that one. I'll get that one, and I didn't realize that, but I've learned it." So that's really really important. The other aspect, particularly for early plastic surgeons, is to pay attention at journal club. Go to journal club, pay attention to journal club, because oftentimes there'll be a paper presented. It'll say, this procedure is better than this procedure for this condition, and then you read through it, and then, okay, well that sounds good, and check the box. Okay, we believe it. And then you'll have some senior surgeon in the back of the room, raise his hand and say, yeah, but the design wasn't good. This control wasn't right. There's bias. There's confounding variables. This may not be actually true. And the difference between the two may not actually be the actual difference in technique. It may be due to something else. And therefore, you started off with, I'm just going to take this paper at face value, to, I'm questioning justification that this proposition is actually true. So that's really, really important. And I think, in this entire research process, the important thing is to be patient, don't give up, keep trying. Early on, it is very difficult to get published papers published, particularly in high level journals. So just keep at it, keep working at it. I think the first thing for PAR is not to lose ground, is to maintain the benefits, the advantages, the attributes that already exist, because PAR really is a forum to be able to exchange plastic surgery information, plastic surgery research across the globe, crossing continents, crossing countries, crossing oceans, crossing boundaries. Plastic surgeons have a tremendous amount of innovation and ideas, and various parts geographically have different patient populations, different issues, et cetera. And learning from people across the globe is critically important. So being able to connect plastic surgeons and researchers in the forum that PRI has is a tremendous advantage, and you don't want to lose that cross-pollination of ideas and innovations. So I think the other thing, and PR is already doing much of this, and I'm an editor for a number of journals in plastic surgery and in general surgery. And I think in this digital publication space, the most important thing, I think, is thinking outside of the box with respect to education for plastic surgery research. And PAR is doing some of this and doing most of this. I would say podcasts, similar to what we're doing today, is very, very helpful. Podcasts are, of course, important in a lot of different spaces. They're very popular. Newsletters highlighting the groundbreaking research in the journals is very, very helpful. To do that, to raise awareness for people to go to the journal and to understand that this study has been published, to help make people aware of new scientific information. Special topic publications, 2, 3, 4, 5 of those per year, which PRI has already done. I think continuing that is very, very helpful. And again, when you're looking at special topics, you want to sort of poll the international audiences. What's important now? What's hot? Whether it's gender, lymphedema, et cetera. There are certain topics that really deserve an intense focus on various aspects of research. And I think one thing, I'm not sure how much PIR does in this, but this is perhaps my best idea for digital marketing, is to have video discussions of various papers, usually some of the best papers by experts in the field. It could be one person, could be two person, it could include the author, et cetera. It could be as simple as a 1 minute, 2, 3 minute discussion where an expert sort of dissects the paper, says, this is what they did, this is how they did it. This is what I think is good. This is what I think could have been done better. This is what I take from it. These are the issues with it. This is how it could have been done better. This is what we need to do next. And this is what I take from it. And maybe this is what you should take from it. And it's important because you have an expert looking at a paper, and that information, particularly if you have more than one, is tremendously beneficial to readers and viewers of that particular digital space. So I would suggest that in the future. And of course, another aspect is similar to the newsletters, is email blasts of groundbreaking publications. Some people don't understand that a great paper has been published, but getting an email saying, hey, look what we have, and maybe include some of the author's quotes, or maybe even a short video of what the author's take of this publication is. And I think that's important because you have to remember, someone who, plastic surgeon who reads a research paper, they spend 10 minutes reading that, whereas the authors have spent 3, 4, 5 months, maybe years writing that paper and performing the research. So they have learned much more than what's in that paper, because there's only so much space to put information in a publication. And you may get a lot of additional information about this topic that isn't in the paper. You may also get things that are really important, like, well, we have this result, but we had a tough time doing it. This was a problem. We didn't have patients in this group. All sorts of aspects that you would otherwise not see. You're basically looking under the hood of that research publication. I think that's another good option. And I think, You mentioned it, Frida, that plastic surgery research is threatened by healthcare economics. And one thing, obviously, is grants. Unless you're doing very important research, getting federal grants that's providing indirects to the hospital that's making money, hospitals don't pay plastic surgeons to do research. That's just not the case. And there is a never ending demand, no matter what country you're in, the demand for more and more clinical productivity, revenue generation is pervasive. I can tell you that in the United States, it's getting worse and worse and worse. Um, and I think, what happens in that situation is you box out plastic surgery research. It's the last thing that people think about, and it's pushed to the side because of the clinical productivity necessary to keep the hospitals afloat. So what my concept is to help avoid this, and I say this, it's almost an impossible task, but I was able to at least successfully um, provide some of this, is to, number one, prioritize research and incentivize research. Now, research is incentivized in that the more papers you write, the faster you get promoted, the more meetings you go to, the more visibility you get, the more visible you become, the better reputation you have, et cetera. But there's nothing better than cold hard cash. Plastic surgeons are humans, and when they're putting food on the table for their family, or they're needing transportation to drive to the hospital, finances help. So compensation models that include research productivity are incredibly beneficial for increasing research activity and research productivity. Having protected time is also helpful, but again, in today's world, it's not all that common to have true protected time. So as a result, it ends up to be weekends and nights, and that means to carve out research time, you're going to be eliminating something. It could be family time, hobby time, etc. And again, formal teaching programs are incredibly helpful, particularly on research topics. I know in my research associate research fellows, I have always had them go through formal research topics, oftentimes sponsored and given by the hospital, specific topics like computer programming and artificial intelligence. I need to pay for those courses because they're not offered for free. But having them, and statistics courses, whatever it may be, particularly study design and scientific writing courses, are incredibly helpful. And I think having them as a mandatory part of research and the plastic surgery curriculum is really, really helpful. So that really sums up, a lot of issues with plastic surgery research, and a little bit of frustration with plastic surgery research. But in the long run, plastic surgery is by far the best specialty in all of healthcare. And I could not personally, after decades of being a plastic surgeon, I cannot imagine being anything other than a plastic surgeon. I just couldn't imagine it. So plastic surgery is the best, despite the frustrations, particularly for the young plastic surgeons. You may be tired, you may be stressed, you may be frustrated, but please enjoy the ride. This is the best specialty in all of medicine. So with that, I think we'll conclude. Frida, thank you very much for inviting me to give these answers to your questions. I hope related some information exchange. I hope there are more questions that came up than answers in here, because questions stimulate more activity and research activity. And again, I'm available. If anyone has any questions or comments, please reach out to Frida to get my email or telephone number, to just reach out to me, to be able to have more exchange. I think the more access plastic surgeons have to other plastic surgeons who are in the field doing similar things, the more we're going to improve our specialty. So thank you.